Hello, this is Dr. Mark Lebwohl. I'm the Waldman Chair of Dermatology at the Icahn School of Medicine at Mount Sinai in New York. I will be discussing safety and efficacy of Apremilast through 104 weeks in patients with moderate to severe psoriasis who continued on Apremilast or switched from Etanercept treatment in the LIBERATE study. This was presented by Dr. Christian Reich and colleagues at the American Academy of Dermatology annual meeting in Orlando, which took place from March 3rd to March 7th in 2017. In summary, compared to placebo, Apremilast demonstrated significant efficacy at week 16 that was maintained through week 104 in biologic-naive patients with moderate to severe plaque psoriasis. Significant improvements in scalp and nail psoriasis were also observed at week 16 with Apremilast and were sustained through week 104. Patients switched from Etanercept to Apremilast maintained efficacy. The safety profile of Apremilast was as expected and did not increase over time. The importance of this study is that many of the medications used to treat moderate to severe plaque psoriasis are limited by adverse events, safety, and tolerability issues, as well as the route of administration. The study indicate that the orally administered Apremilast may be an important treatment alternative in this patient population. Now let's talk about the study design. The LIBERATE study is a randomized, placebo-controlled, multi-center phase 3b study. It involved biologic-naive patients with chronic, moderate to severe plaque psoriasis, as demonstrated by PASI scores greater than or equal to 12, a static physician's global assessment equal to 3 or moderate disease, and a body surface area involvement greater than or equal to 10%. Patients who had an inadequate response, intolerance, or contraindication to at least one conventional systemic agent were included. Patients were randomized 1:1:1 to receive either Etanercept 50 milligrams once weekly, Apremilast 30 milligrams twice daily, or placebo. At 16 weeks, Apremilast patients continued treatment, while the Etanercept and placebo patients were switched to Apremilast 30 milligrams twice daily. Treatment was continued through week 104. Starting at week 32, all non-responders, and that was defined by those who were less than PASI 50, had the option of adding topical therapies and or UVB phototherapy. 250 patients with a mean PASI score of 19 to 20 at baseline were randomized. The mean duration of psoriasis ranged from 16.6 to 19.7 years. A PASI 75 score at week 16 was achieved in 39.8% of Apremilast patients, 48% of Etanercept patients, and 11.9% of placebo patients. The differences were statistically significant compared with placebo. A PASI 75 score at week 104 was achieved in 45.9% to 51.9% of patients, with no statistically significant differences between the three groups. At week 16, significantly more patients treated with Apremilast or Etanercept than placebo achieved a minimally clinically important difference in the DLQI, which is a quality of life tool. Responses in the Apremilast and Etanercept switched to Apremilast groups were maintained through week 104. Among patients with at least moderate scalp involvement at baseline, significantly more patients treated with Apremilast or Etanercept than placebo achieved a response of clear or almost clear at week 16. The response was maintained or improved through week 104. Similar findings were observed with respect to improvement in nail psoriasis. The incidences of adverse events were similar among the three groups from week 16 through 104, occurring in approximately 2/3 of patients. Diarrhea was the most frequent adverse event in each group. There are a number of important take-home messages from this poster. It is noteworthy that at week 16, 48% of Etanercept patients and 40% of Apremilast patients achieved PASI 75, both reasonably good levels of improvement. It is also noteworthy that results in scalp psoriasis were a little bit better than in body psoriasis, a finding that has occurred in other studies as well. It is not surprising that the improvement in nail psoriasis lags behind the improvement in body psoriasis and scalp psoriasis. Nonetheless, given enough time, the nails do start to catch up. So the bottom line message is that switching at week 16 to Apremilast 30 milligrams twice a day did result in continued improvement in all of the arms, or maintenance of improvement in the Etanercept arm. And finally, it is noteworthy that between week 16 and 104, the patients who had started on Apremilast and continued on Apremilast had only a 5.4% frequency of diarrhea, which was lower than the other two groups, suggesting that perhaps patients who developed diarrhea during the first 16 weeks and were at most risk for it may have dropped out during that period, or suggesting that patients acclimatized to the diarrhea and ended up having the diarrhea go away as a symptom after a short period of time. Regardless of what the reason was, the rate of from week 16 to 104 was quite low in the group that continued on Apremilast.